All right, well, we'll go ahead and get started. I'm Karen Kurtz and I am on the Disability Awareness Team. And today we are really lucky to have Jessica Roberts, who is a nurse practitioner. And she is the director of the Michigan Medicine Support Group and also in the Cardiovascular Disorders Center. And Dr. Mollie McDermott, who is a neurologist and now the chief of staff at the hospital, but her main interest is stroke research. And we are just really lucky to have them here. I had the pleasure of working with both of them in my career, and so I'm extra excited to have you here. Thank you.
Thanks for having us.
Do we want to introduce who else is in the room, or?
Sure, we can do that. Okay. Wendy.
Hi, I'm Wendy Everett, and here at the church, I'm in charge of adult faith formation activities like classes like this and Bible studies and small groups. And when we go
Next to Karen is Donna Wagram, my friend, and next to me is Jean Krieger, who is my neighbor. And I'm Ann Hanton.
And I'm Amy Kennedy, and I'm Minister of Congregational Care.
Great.
Thank you all for being here.
In the Zoom meeting, if you don't, I'll ask you, how about Mary, Sarah, and then Janet?
I'm Mary McCluskey. I'm on the Access team, and we have a great group that helps organize these sessions. So, Sarah?
Sarah Newden, I guess it's a long time member now. It's hard to believe, but of the church. And Larry's going to be joining.
Jan, you're muted.
I'm Janet Pogler, and I'm also on the Access Committee, and I'm coming to you from Colorado.
Mary, you're muted.
It's inevitable.
It always happens.
Jan, I just wanted to point out, Jan also leads a stroke support group here at church.
We should share notes.
What, I didn't hear what she said. There's a stroke support group here.
That's what she said.
The caregiver support group.
It's a caregiver,
Like here.
a variety of
Okay.
caregiving.
Very cool.
Yeah.
Very cool.
I can get something out of the.
Where's Larry?
Hi, Larry.
Hi, hello,
Welcome.
thank you.
And maybe if you would introduce yourselves just one more time for us.
Yeah, hi, I'm Jessie. I'm a nurse practitioner. I work in the stroke clinic over at U of M, and we're here to talk about stroke. So thanks for having us.
Hi, Mollie McDermott. I'm a stroke neurologist over at U of M, and I'm the director of the stroke division, and delighted to be here.
Thank you. Is it time to bring up your PowerPoint?
Sure.
Okay.
Did anyone else need to introduce themselves?
All right. Did we get everybody introduced?
Great.
I think we did. Okay. So those of you on Zoom, Amy Kennedy is going to monitor the chat and whatnot, because I won't be able to see you while I have the presentation shared. So let me pull that up. Let's get some things out of the way here. There we go. So just say next slide or something.
Okay, yeah,
Go to the
awesome.
next one.
So thank you so much for having us. I want to keep this as, informal as possible. So just feel free to interrupt, ask questions throughout, right? More like a group discussion. We have some slides to go over, but this is all in our heads. So, whatever you want to talk about, you have any questions, just please let us know. But we're here to talk about stroke, stroke, what causes stroke, what is a stroke, and how do we prevent stroke, right? And then also a little bit about recovery as well. So let us know if you have any questions. But yeah, again, I'm Jessie, and this is Dr. McDermott, and this is our passion. We talk about this all day, every day. So, we are delighted to be here. Next, yep, and we have no disclosures. We're here on our own free will. So, yeah. Okay, so, what is a stroke, right? And, a lot of people, have heard the word, but often aren't really sure what it actually means, right? And stroke is essentially when there is a disruption of blood flow to your brain or part of the tissue, right? A certain area, for whatever reason, is not getting blood that it needs to survive, right? And, therefore it stops functioning, right? And so sudden neurological symptoms arise, right? And there's really two different types of reasons that you can have a stroke. Next slide. And that's either, oh, come in. Yeah. Welcome. There's two different types of stroke, and that's an ischemic stroke, right? And which is the most common type of stroke, usually encompasses about 85% of the types of strokes that you can have. And that is where an area is deprived of oxygen, right? Meaning that there is a disruption of blood flow, okay? So something goes into the artery that feeds blood to that tissue, whether it becomes narrowed, that artery becomes blocked, but for whatever reason, the blood isn't getting there, right? So then the brain tissue is not getting that oxygen-rich blood it needs, right? And therefore, almost immediately starts to become dysfunctional, right? And so whatever area is affected, right, that's when your symptoms will arise. And then there's a hemorrhagic stroke, which is a less common reason people have stroke, but around 15%. And that's when there is something where an artery bursts and the brain tissue becomes flooded with blood, right? And then the brain tissue essentially cannot function for that reason, okay? Any questions or thoughts about that? Okay, go ahead, next slide. So this is just a picture of, when we're looking at stroke, right? You can see the hemorrhagic stroke is there with the big white kind of brightness on the right-hand side of the screen. And then an ischemic stroke is that dark tissue. All of that is the tissue that is affected from the stroke, right? So meaning that tissue is usually no longer functioning, right? Okay. We'll go ahead to the next slide. Yeah. So then there's a subset of stroke, and people used to call these mini strokes, right? But it's a transient ischemic attack, or TIA. And that's when it's a subset of ischemic stroke, meaning there is a temporary blockage of blood flow. So something goes into that artery, blocks blood flow, and symptoms arise almost immediately when that blood flow is blocked, right? But for whatever reason, that blood flow spontaneously is restored, and the brain tissue then is able to function like normal again, right? So that brain tissue then is functioning again, but that blockage there, right, has essentially broken up for whatever reason, meaning you're not having permanent neurological symptoms from that, right? We all often take this as a warning sign, okay? There's a 15% risk of stroke within 3 months after a TIA, right? 40% chance of stroke in 5 years, right? And so it's a medical emergency. Super important that if you have these symptoms, even if they resolve, right, that you come in to the emergency department, because we can help figure out why did that happen and hopefully prevent a more devastating stroke, right, or permanent brain tissue damage, okay? So TIA, transient ischemic attack, temporary neurological symptoms that resolve, right? But we take just as serious as a stroke, okay? Thank you. So super important, right, that you call 911 if you have those types of symptoms. And it is very important that even though the symptoms have resolved, you still come into the emergency department, or at least talk to your medical provider, okay? Next slide. So, 250,000 people, right, have a stroke in the US annually. It's a lot of people. Come on in, guys. Yeah. And someone in the US has a stroke every 40 seconds, right? So it's devastating. It's very common, right? Very common. The next slide, welcome, hi.
Okay, very briefly, we're recording this session. I just remembered a few people walked in after we announced that, so.
Okay, and this is just a figure that kind of represents those older than 18 years old who have a reported history of stroke, and it's kind of broken down by state there. So you can kind of see the darker blue is where stroke is more common, kind of down, and we call that kind of the stroke belt, which right down south. And goes up into Michigan as well, where around 2.7 to 3%, okay, of Michigan people 18 years or older who have had a stroke. So that was back from 2005. So it's very common. We'll go ahead and next slide. Okay, so it is the first leading cause of disability in the United States, right? And second leading cause of death worldwide, okay? But fifth leading cause of death in the United States. So, often it's not causing, death, but disability much more common, right? And so can be quite devastating, right? The good news is, and go ahead, next slide. The good news is, sorry, I forgot this slide was next. That's okay. Yeah, so I want to go back to stroke death rates as well, which can be, you can kind of see the cluster of dark purple and, really the southern region there and going up towards Michigan as well, around 70 rates per 170 per 100,000 people. And so, as I said, that can be still, the fifth leading cause of death in the United States. So, it can be, go ahead.
Yeah, sorry, just-
please, yeah.
And does anyone have a guess why?
That's what I was just gonna
Yes,
ask.
yes.
Okay, yeah.
Outdoor activity,
What's that?
outdoor activity.
Maybe, that's hard to study, but conceivable.
Could be diet.
Yeah, it's uncontrolled risk factors. So especially high blood pressure, but also other risk factors that Jesse's gonna talk about.
Yeah,
So
yeah, so, diet, inactivity, right? Really high blood pressure. Those types of things are more common in the areas where risk is higher there and where the rates are higher. And so, yeah, we'll get to that in our next slide. So that leads me perfectly into my next point, right? Is that there are lots of risk factors for stroke. Some you can control and some you can't, of course, and we'll talk about the most important ones, okay? Go ahead, next slide, thank you. So risk factors, of course, you can't control, right? And increasing age, right? We all increase in age, it's inevitable, right? And that is a risk factor within itself. Race, certain races are at a higher risk. African Americans, our Black population, Hispanics are at a higher risk, which is usually correlated as well with high blood pressure, which that population is also at an increased risk for. Family history, if you have a family history of stroke, that increases your risk of stroke. And then a previous stroke or TIA. Once you've had a stroke or a TIA, you are at a higher risk of having another, okay? But the good news is, next slide, that there is risk factors that we can control, right? And, I usually counsel lots of patients is that stroke is very preventable and there's lots that we can do to help prevent another stroke, okay? High blood pressure, controlling your blood pressure is the most important thing that you can do to reduce your risk of having your first stroke or a recurrent stroke, okay? And so if you have high blood pressure, I urge you, right, to keep an eye on it at home, and follow up with your doctor, about what your blood pressure should be running, right? So and that's something that you can directly control and take charge of your health. High blood pressure, I can't emphasize how important that is. Quitting smoking, okay, if you smoke, right? Smoking is one of the biggest risk factors for stroke. So definitely try to quit smoking. And there are tons of resources to help people quit smoking. So if you're smoking, vaping, I urge you to quit, okay?
Has that gone down considerably?
The smoking. Yeah, smoking has gone down. Vaping is high in the younger population, right? We don't have a lot of studies about vaping right now. But tobacco smoking, while it has gone down, right, people still do smoke, right? And it certainly increases your risk.
As does marijuana smoking.
Yes, yeah. Yeah. And so, inactivity, right, increases your risk for stroke. So exercising, the easiest thing that we can do, right? 30 to 40 minutes, 3 to 4 days a week, upwards of something that is getting your heart rate up, right? So, I like to talk about, slowly getting there, right? But the goal would be this moderate intensity exercise. So that's where you're kind of able to have a conversation with someone, but you're winded, right? But you can still kind of hold a conversation, and that 30 to 40 minutes, that is the goal of this moderate intensity exercise. But if you're just starting out exercising, right, 10 minutes 3 times a day can get you there of just walking, right? Break it into tiny little chunks. Go 10-minute walk in the morning, lunchtime 10-minute walk, nighttime 10-minute walk. And that's a really good way to start exercising. You just start out 10 minutes once a day, right? So exercise, super important. And then maintaining a healthy weight, of course, is very important. And BMI can be variable depending on, your bones and, your muscle mass, but just maintaining a healthy weight can be very important. And then the diet we recommend for our stroke patients, or really anyone to help prevent cardiovascular disease and stroke, is a Mediterranean diet. And that kind of focus on lean proteins like chicken and fish, staying away from red meats, right? And I'm not saying you should never eat it again, right? But everything in moderation, right? So Mediterranean diet is really just focusing more on those lean proteins, less red meat, olive oils instead of the butters and the fatty margarines, right? And more like vegetables and fruits and whole grains instead of that white refined grain, right? That's really the Mediterranean diet, which is that heart healthy type of food. Yeah. Any questions about those risk factors, guys? Things that you can control, because that's super important. Okay. All right. Okay. Yep. And then here's a nice little pyramid about the Mediterranean diet. And it kind of breaks it down, as I kind of went over already. But this is just a good thing for really anyone who, is trying to maintain a healthier lifestyle. It's a nice little adjustment to the traditional food pyramid we're used to, right? Yeah. Okay, next slide. And so if you've had a stroke, right, one of the most common medicines we typically put you on is a baby aspirin, or 81 milligrams of aspirin. And that's if you're not on a blood thinner because of another reason, a blood thinners like warfarin or Eliquis, then usually you're on an antiplatelet, which we call aspirin or Plavix, okay? And that's a really good way at preventing stroke and can reduce your risk of stroke by upwards, they estimate 10 to 15%, just taking the baby aspirin, okay? Cholesterol medications, helping to lower your cholesterol. That's something that we work on with all of our stroke patients, and we try to get that bad cholesterol. It's called LDL. We really work towards getting that less than 70, okay? And we see that higher levels of that bad cholesterol increase your risk of stroke. So putting people on cholesterol medicines is a really good way to prevent a future stroke, okay? Medications, of course, for treating diabetes, right? So like metformin or insulin, things that really can help control your glycemic index and preventing, diabetes if you don't have it, right? Is super important. But if you are diabetic and you've had a stroke, it's very important that you try to control your diabetes the best that you can, okay? And even more important for our patients who have diabetes, that their blood pressure is under control as well, okay? And going again to blood pressure, medicines, of course, we have lots of medicines to help treat your blood pressure, various, different medications, but really it's just targeting a really good blood pressure goal. And for most people in general who have had a stroke, that goal is less than 130/80. Okay, that's a number that we usually try to treat if you have had a stroke. Okay, same with TIA. And then again, blood thinners, if you have an abnormal heart rhythm, and that heart rhythm is called atrial fibrillation. Okay, atrial fibrillation is where your heart kind of beats erratically, and those top two chambers aren't beating effectively. And when they aren't beating effectively, a clot can form inside those chambers, right? And so a really good way at preventing that clot from forming is by going on a blood thinner, right? And that blood thinner can prevent clots from forming and drastically reduce your risk of having another stroke if you have that abnormal heart rhythm, okay?
Does exercise affect the heart chambers also?
Does it affect the, does it affect the heart chambers?
Blood flow.
Yeah, well, it doesn't cause irregular rhythm like atrial fibrillation, but it can certainly help improve the overall function of your heart. Yeah.
So the clots are less likely to form?
Oh, yeah. So, well, I think if your question is what causes AFib, is that the question?
No, if exercise, it exercises the heart also, right?
Yeah, oh yeah,
And that,
absolutely.
like,
Yeah, and it helps that heart pump more effectively, right, in a healthier way, and helps so when you're exercising, right, our goal is to really help that heart squeeze effectively, and it helps it so that when you are in a resting state, the heart pumps more effectively, right? And so when you're exercising, you're increasing your heart rate, and that helps your heart muscle work, right? Just like we're working the rest of our muscles and building strength, exercise builds that big muscle, the heart, right, in the same way.
And that helps decrease the likelihood of a mini stroke?
Well, it helps prevent high blood pressure, right? And when which also causes stroke, exactly, yeah, yeah.
But to your question about does exercise reduce the risk of a clot in the heart? I don't think so, actually.
Yeah.
It would reduce the risk of a clot in your leg. When people get like a DVT from immobility or being on an airplane and not moving. But I don't believe we would say that it would reduce the risk of a clot in your heart.
Yeah, so I think to kind of reiterate exactly as Dr. McDermott is saying, atrial fibrillation is an electrical abnormality of your heart, right? So exercise wouldn't cause that electrical abnormality, or cause a clot in your heart, yeah. Or vice versa, it wouldn't reduce that risk, yeah.
I have a question. Whenever I've gone to the ER, one of the first things they ask me is, are you on blood thinners? Because usually it's some accident or, like, is there, like if stroke is such a high cause of death and disability, obviously we should be on blood thinners, but what's the risk of other problems from the blood thinners? Is that a significant risk being put on a blood thinner? Because I know several people who are on blood thinners, and I just wondered, like, do people run into other kind of complications?
We've looked at this, the risk of being on a blood thinner is that your blood is thin, and so you bleed more easily. So head trauma could lead to bleeding. People can experience nosebleeds. Any little cut can bleed more commonly. It's interesting, there's a decision analysis to try to help guide folks with a lot of falls. So people that fall a lot, there's this question of, should you be on a blood thinner or not because you're falling and run the risk of having a complication? You'd actually have to fall 295 times in a year to not make the blood thinner worth it in terms of reducing disability. So, and I think that there are other, and I think we can sort of extrapolate that the risk reduction from a blood thinner is so powerful in the setting of atrial fibrillation that it almost always outweighs the potential risks.
I have a question about that. Years ago, my husband and I were told to take a baby aspirin a day, and we did for a long time.
Yeah.
And then our doctor said,
No, don't take that.
probably you shouldn't be on that, so I'm not. And now I'm reading, oh, maybe I need to be in order to
In the same
prevent
place.
stroke.
Yeah, we used to say that like if you reached a certain age, you should be on a baby aspirin.
I probably have.
But now, now age is not enough, there needs to be another indication, so coronary artery disease, history of stroke. Then you would qualify, but not all comers, so
Okay.
so those recommendations have been amended.
Continue to follow my doctor's
Yeah.
advice.
Probably always a good idea.
And can I ask, what's the age that prompts you to say, oh, you should be on a baby aspirin?
None,
Oh,
yeah, so
okay.
you really need coronary artery disease or a stroke.
Okay,
Yeah.
so now there's.
Yeah, so
Is it possible that if you stopped, like Anne took it and then we were told, no, don't do it. I had a stroke. So I didn't take it. Is that, could that have added to it, or I take it now, obviously?
sure.
In the very short term, after stopping antiplatelets and anticoagulation, the risk of stroke is up, but that's like in the first week. And then it kind of goes back to the normal population.
Yeah, thank you.
That's a good question.
Thank you.
Yeah. Good
Larry,
questions.
Larry has a question.
Yeah, go ahead.
Hey, Larry.
Was it Larry or Mary?
Larry,
Larry. Larry?
Larry and
Maybe Larry's on
Sarah, you
mute.
need to unmute. There you go.
Oh, I thought it was turned on, sorry. Okay, on the question of the use of a low dose aspirin and blood thinners, so to speak. The advice now is that if you don't need it, then you avoid it. But I had to wrestle with this and had a lot of conversations with cardiologists about it as well. But I use baby aspirin, the 81 milligram aspirin. And even though I'm at some risk for hemorrhagic stroke, but there are other ways of mitigating that. And with that in mind, the exercise and the diet can be subdivided quite a lot. You know, there are a lot of little things that can make a big difference, and it can be tailored a little bit to people with special needs. But that's a whole other subject. But I might say that getting the science behind this, the underlying physiology into practice can take a very long time. Having observed it personally over over many decades. Anyhow, I'll make some other points later on.
Thank you, Larry.
Now, how do I get back to the?
Yeah, so any other questions about stroke prevention treatment? So these are for patients who have had a stroke, that I would apply these to. And next slide. Okay, so I want to ask you all, signs and symptoms of stroke. Does anyone want to guess, or have they learned anything? An acronym maybe?
Smile.
Ah, that's a good one. Yep,
Remember
so
what
that's
it
the
stands
S,
for.
that's the S, right?
That's the yes.
I know, sticking your tongue out and if it goes crooked is.
Yeah,
that you
yeah,
could
that's a
back
sign.
check on.
Yeah. Okay, so go, I'll
I
hold
didn't
it
know that.
fast. Good, okay, there you have it. Go ahead into the next slide. Okay, so there we are, fast, right?
Yeah.
So,
Yeah, but
this-
when I had my stroke, I had a big sign on my refrigerator and.
It didn't know.
what were your symptoms?
Total exhaustion because I had my husband in the hospital.
Yeah.
And I took him to the doctor.
Yeah.
Then I took him to the emergency room and it was 36 hours awake.
Oh,
Beside all this other stuff.
yeah,
I got home, I was sitting with him and my I said to my sister, I can't find it. I'm just exhausted.
Yeah.
So everybody's thinking I'm exhausted, right?
Yeah.
So I get home, she drops me off, I go in the house. And I was hungry, so I reached into the refrigerator. And I had a piece of quiche that I had eaten. I didn't know.
Oh,
Yep.
dear.
It's a weakness.
Then I stumbled and fell into the kitchen cabinet. And this is stupid, go lay down. Went to lay down. And 3 a.m, I tried to use my phone to call 911 because I was alone. I don't know how it worked, but it worked. I didn't remember to put it in. I didn't remember to talk to Siri. I didn't,
Yeah.
somehow it worked. They said, open the door. I said, I'm alone, Kim. Or somewhat like that.
Yeah.
And luckily the firemen went around the house, found a window open, cut the screen and came in and they all took me to the window.
Thank you for sharing that with us.
And here I am.
A year later.
A year later.
Yeah.
Thank you for sharing that.
Yeah.
And that had to have been scary.
It was extremely scary. Yeah,
Yeah.
but 2 things. One, I mean, get there and try to remember that and try to remember how to use your phone
Yeah.
or your watch, because you use it. And then they suggested I stay in the hospital 2 extra weeks and go to therapy. And that to me was the best advice. 3 hours a day,
Intensive there.
they didn't fool around. And then I went home and I had the home therapy. Not so much.
Yeah.
Once a week, 15 minutes.
Intensive
And then I
there.
went across the street we happened to have a ATI across the
Yeah.
street, so I went there and they were great too.
Yeah, yeah.
But the therapy is really important.
Well, thank you for sharing that. And I think that the super important message here is FAST, right? So it's an acronym that we use to help people remember the signs and symptoms of stroke, right? So facial drooping, that's F. Arm weakness, right? One-sided arm weakness. Speech sounds strange, coming out slurred, or words aren't coming out. You can't understand what someone is saying. So kind of speech is jumbled or words are mixed up and they're not making sense, right? So FAST. You ever see symptoms like that, it's time to call 911. So I'm going to reiterate, one-sided weakness. Okay, so weakness or numbness that comes on suddenly to one side of your body, sudden difficulty speaking or understanding others, right? Sudden room spinning dizziness with nausea and vomiting, right? And you can't walk, you're calling 911 immediately, right? So FAST is the acronym that we use, okay? One-sided weakness, numbness, difficulty speaking, understanding others, sudden vision loss, your vision goes one eye, okay? Or sudden severe double vision, okay? Those are symptoms of stroke. Yeah.
Do you remember? I don't get. I can't tell you if you remember.
Your symptoms?
Yeah.
I can't, I'm sorry, Donna.
And I don't remember it.
You don't remember what, yeah, yeah.
No. I was calling and said,
Yeah.
it's.
Yeah.
I just don't remember.
The hard thing with stroke is that 1 second you're totally normal. The next, you're not, right? It's just like that, right? So it comes on suddenly, okay? And the important thing is that you call 911 because whatever is happening, right? Or if someone's with you, right?
There's nobody there.
Yeah,
That's
yeah,
the scary
yeah,
thing.
yeah,
is
yeah,
living
it's very
alone.
scary, right? So bringing up a good point for people who live alone, right? And I know when my grandmother moved in alone, we put a life alert button on her for this very reason, because that's scary, right? Right?
Man, was it, I wear a watch.
Yeah,
I can't know if I can dress them up.
Yeah, yeah.
I think I remember hearing you didn't show up for a dentist
That's
appointment,
right.
and they called to check on you, right?
And then.
Yeah,
when you
that's
answered,
right.
you
Yes,
were,
yes, yeah.
Not able to talk well on the phone.
Yeah. So,
So is
Yeah.
there something that they do for you in the ambulance? Is it, if the person isn't bad enough and they don't live alone, can someone take them to the emergency room?
sorry, say it again.
Well, I'm wondering the difference between calling 911 and having someone take you
So
to the
great,
emergency
great
room.
question. So that's what we go to the next
Oh.
slide. Yeah, that's a
Is it
great
ahead of you?
question. So I just want to put that up there. But, no, so calling 911 is super important because the ambulance is trained at taking you to the closest hospital that has a team on site that can give you the life-saving treatment that you need, that can help restore that blood flow, right? So calling 911 is so important because they can get you there. They can let the hospital know ahead of time, right? That you are coming and we have a potential stroke patient, right? Because there's this medication, if you are having an ischemic stroke, it's called TNK. Used to be called TPA, and what it does is it helps break up that clot, right? So when you're having a stroke, there's this area where the blood flow isn't getting to, right? And there's an area that almost immediately starts to die, but then there's this supported tissue on the outskirts, right? That's kind of being fed by different arteries, and that area can only last so long. But if we can restore the blood flow to the main pathway with this medicine, then we can help save that brain tissue. We call it the penumbra, and we can help restore the blood flow. And we have a medicine that helps break up that clot.
And that wouldn't be till you get to the hospital. but
Exactly.
Not
Yep,
in the
Yep, and it's
ambulance.
important that you get a head CT before you get that medicine, because we wouldn't want to give that medicine if you had a bleeding type of stroke, right? Because we don't want to make a bleeding stroke bleed more, right?
Yes.
So that's why it's so super important.
Okay.
And that medicine, I don't think I got it.
Yeah.
My understanding was because there was too much time.
It's time sensitive, and yeah, so that, I was just gonna say, that medicine can only be given within 4.5 hours of symptom onset, yep. So it's very time sensitive. We do have another, and Dr. McDermott, I believe we'll get into this, another treatment that can go and pull the clot out, that can be given outside of that time limit, and we'll get to that in a minute, yep. So there's the symptoms I talked about. Worst headache ever, right, is something I didn't mention, but that's a hemorrhagic stroke, sudden severe. My head's gonna explode type of headache, right? You ever have that, call 911 as well. Next slide, great. Yep, and so this kind of goes over a little bit more of what I talked about. So difficulty with understanding what you're reading, or you can, and this is what Karen's so good at, right? Our speech language pathologist, difficulty with getting your language out or understanding language. Next slide. And then the vision changes as well, can be a symptom of stroke. So double vision, vision loss, blurry vision. We don't associate alone with stroke, but more sudden loss or double vision. But if you're having a hard time concentrating your vision and it came on suddenly, always good to get that looked at as well. Yeah. Next slide. Yep.
Yeah, so I'm gonna take over here. So this is a map basically of how our body parts are laid out in our cortex, which is the outer rind of our brain. And so stroke symptoms can depend on where the brain tissue is injured. So if it's injured in the part of your brain where your language is, you'll have trouble with your speaking. If it's injured in a part of the brain where your hand is represented, you'll have trouble with your hand moving. So it's kind of an interesting design. I think as you know, the right side of your brain works the left side of your body and vice versa. We don't really know why we're built that way, but that's how we are built. This is called the homunculus, which is a kind of funny word. This is the map. And when we show this for the first time to medical students, they always kind of giggle because your legs are kind of standing on your genitals, if you'll notice in the inner hemispheric fissure. So, all right, next slide, Wendy. So I think neurologists are a bit jealous of cardiologists because when patients are having a heart attack, it hurts. And so they call 911 because they want the pain to go away. But often with neurologic symptoms, you think, oh, that's annoying, but I hope it gets better. Or, oh, that's weird, it's numb, but you know, it'll probably get better. And there's not necessarily like a huge driver for people to go to the emergency room like there is with a heart attack, which is why we were doing an activity like this today to say, if you have symptoms concerning for stroke, call 911. Get to the emergency room. No one will fault you if you think you're having a stroke for calling 911. Everyone will say, good job. That was the right thing to do, even if it turns out it wasn't a stroke. So the reasons people don't call 911 are that they think their symptoms are too mild, that they hope the symptoms will pass, as they've said, because symptoms don't hurt. They think calling 911 is overkill because of language issues where they can't talk on the phone. Or they have weakness so they can't get to the phone, or interestingly and specific to neurology, you may not be aware of your symptoms. So there's something called anosognosia, which is where if you have a right brain injury, you actually don't necessarily even know that you have a problem on the left side of your body. So you're not even aware of it. It can be profound to where when we first see patients with large right hemispheric strokes in the emergency room, will hold up their left arm and say, whose arm is this? And they'll say, yours. They don't even recognize their own arm because of, again, just because of how we're made. So that can be a reason people don't call 911.
Could I interject real quick?
Yeah.
I had a discussion with my parents who are in their late 80s about this. And I know my dad had had a fall and my mom drove him to the ER and it was kind of a disaster. So they did want to call 911 because it cost too much for the ambulance ride. And they felt perfectly fine getting in the car and driving. She was able to get him in the car for his fall. But she did admit she was overwhelmed driving and thinking about what was going on with him in the other seat. And then she took a wrong turn. And she ended up driving wrong way on a one-way street. And I mean, it was just one thing after another. You call 911, the people who are experts, who are not emotionally involved, come really fast, take care of what they need to do to get you in the vehicle and get you started and notifying the hospital ahead. So that to me is another part of it that it was interesting to have that conversation. I'm glad I had that conversation with them to find out what had happened.
That's a great point. So
And they won't do it again.
I hope not. Well, we can't control our parents. So there was, when we hear that someone is coming in, so the ambulance drivers will call the emergency room and say, hey, we're 10 minutes out, we're bringing in a patient with stroke symptoms. We actually hold the CT scanner so that it's going to be open to bring the patient to. We go down so that we are meeting the patient while they're being rolled in, and we can start our assessment right away. So you've said time is really important. It helps us dramatically decrease the time. You actually get brought right to the bay where we treat patients with stroke. You don't have to go check in at the front desk and all that kind of stuff. So it's really not overkill. It's really important.
And the point that you made about calling 911 and getting there, and you shouldn't, there was nothing. After having a stroke, of course, I was panicked. And a couple months after, I was like, called the doctor. The nurse was just questioning. She finally said, I think you have to go. I said, and she said, I'm calling the ambulance. They came in, they had been at our house, I don't know how many times for my husband. So they walked in and walked right past me.
Oh, no.
And he said, not this time. So then I got there and they weren't sure either.
Mm.
So I was admitted overnight and it turned out it was fine.
Yeah,
But nobody made me feel bad.
good. They should,
So-
yeah.
I think that's important, that if you're questioning it, go.
That's great.
If you can call 911, but you're having trouble speaking.
They'll send
they-
someone.
Yeah, I
Send
was
someone.
gonna say,
Yeah,
that's-
Well, even your phone, like if you drop it or something, you know, or report a problem or an
Yeah.
issue, like it's.
My toddler has definitely called 911 on accident with that,
Oh.
you know, cause you press that button and then it's, what's going on
Yeah.
here?
And I'm like, no, I don't need,
Yeah.
cause I had
It's
the police stop by
interesting.
my house one
I'm
time, yeah, sorry.
Walking around my backyard and I bump into something, or if I'm just hammering on something,
Yeah.
the phone will go crazy. It said, did you just fall?
Yeah.
I said, no, I didn't fall. I didn't fall.
What were you saying, Wendy?
Yeah, it just was embarrassing one time when the police did stop by my house. It said I called 911. I'm like, I did not, I really didn't.
Hmm.
And he's like, you know, then he wondered, he's like kind of looking behind me, is there something specific?
Right,
going on here that, you know, are you,
Oh,
you know, is there
In
some kind of
trouble.
abusive, you know, they're just like, he questioned me for a minute and then he left, but still it was.
And if you're like me, you always feel guilty when you're talking. I'm like, I had done nothing wrong, but somehow I feel guilty.
See Larry's hand raised.
Okay.
So
Yes.
that's if Larry-
Yes.
Go for it. Here, let me pull up, see if I can.
Yes, I'm on, I think.
Yes.
Yeah.
Yeah.
I'd like to relate a positive 911 experience, which people will find reassuring. Sometimes I have to work in remote rural areas in very tall grass where you're really invisible. And once in a while in the process, I'll bend the smartphone in a way that triggers 911. And the phone rings and I pick it up embarrassed, you know, and they say, are you okay? Do you need help? And oh no, I'm sorry. I bent the phone there, but I also asked, can you GPS me? Yes. That's the kind of geo positioning.
Yeah.
So can you find me? You know where I am.
Neat.
So we have that backup here.
That's nice.
Thanks, Larry.
Thank you.
All right, Wendy, if you can move to our next slide. Okay, so I think one of you asked, okay, but why? You know, what can you do for me in the emergency room? And there are treatments that we can give if we think someone may be having a stroke, but we need to give them quickly. Millions and millions of neurons die every minute that you are not getting blood flow to your brain. So we take time very, very seriously and try to get folks treated as quickly as possible. It's really important for us to know when the symptoms started or when you were last known normal, because that's when the clock starts. So as Jesse said, we have 4.5 hours to give the clot busting medicine, but if we don't know when you were last known normal, we don't know where that window is, and so then we can't offer treatment. So I think the T in fast is for time, get to the hospital quickly, but I would urge also to just check and see when the symptoms developed, because that's really helpful for us to know. Next slide. And next slide. Okay, so what happens when you get to the hospital? So it's a bit of a symphony of medical providers, all kind of yeah, it's a lot of people swarming around you. So we have to quickly get lab work, get a blood pressure, get often an EKG, send you for the CT scan, put in an IV. There's just a lot that has to happen. And I'll often tell patients when I see them in the emergency room, a lot's about to happen really fast, and I'm going to be talking to you, and I'm going to be a little bit rude because I have to get some information from you, and I'm going to redirect you if I think we're headed down the wrong path. And then I'm going to come back later, I'm going to apologize, and I'm going to answer all your questions. And so, because we're really trying to figure out, when did the symptoms start? What medicines are you on? You know, sometimes we're trying to figure out, is this disabling for you? Because the medicines that we have are not without risk. So a little bit of numbness in your right finger we may say, you know, if worst case you end up with that, you can live with that. Unless maybe you're a pianist for your career, and then, you know, that changes the calculus. So there's a lot of information we want to get quickly. And so you'll be evaluated by the ER doctors and nurses, the neurologist. The pharmacist will help us make sure we have the right weight so we can give the appropriate dose of medication. Labs will be drawn, and then you'll be rushed to the CT scanner to get a picture of your head. Next slide. In some communities, there are not neurologists. And so we work with like the My Michigan Health System and the Munson Health System in the northern part of the state via a program called Telestroke, where we neurologists actually video into the room where patients are. And then we can talk to the patient, ask them to, you know, do things to try to figure out what their symptoms are, and then make recommendations to the local ER physician about whether they should be treated or not. So we have 9 hospitals that we partner with in this way. And I think we're seeing now, I think it's over 2,000 people a year. So it's really busy, but a really nice resource because there is a shortage of stroke neurologists. And so it's a way of kind of trying to spread the knowledge throughout Michigan. Next slide. So how is stroke treated? So the goal, as Jesse said, is to try to restore blood flow to the brain. And there's 2 ways of doing that. So basically you have an artery, it's plugged up. You can either, you know, when your pipes are clogged, you pour liquid plumber down. So the medicine's sort of like liquid plumber to try to break that clot up. The other way is to try to go in with a catheter and actually pull the clot out. And those are the 2 treatments we have, at least in 2025. I think in 25 years, we'll have potentially cooler treatments, like potentially even external beams that can help break up clots. I think that's probably where we're headed, but in 2025, those are the 2 options. Next slide. So the medical treatment is called TPA or TNK. They're the same thing. It's a clot busting medicine, and the goal is to break up the blood clot causing the stroke. It thins your blood at the site of the clot causing your stroke, but it also thins your blood everywhere else because it's a medication that goes in your IV. And so when we give this medication, we watch people really, really closely to make sure that they're not having issues with bleeding. And so after this medication, we actually check vital signs every 15 minutes, do neuro exams every 15 minutes, then it converts to every hour. And so after patients have received this medication, they're guaranteed to have like the worst night's sleep of their life because we just keep a really close eye on folks who have gotten this. Next slide. So TPA, if given quickly, increases your chance of little or no disability by up to 30%. And so if you look at this people map, it shows that for people that receive TPA, because it's a heavy duty blood thinner, 3 people might have a problem, but many, many, many more will benefit from the treatment. And it can only be given within 4.5 hours, except for some rare exceptions, which are too niche to kind of get into. But don't look at your watch and say, well, it's been 4.5 hours, so I'm gonna have lunch and then I'll drive myself in. No. You may still qualify, so please come into the emergency room quickly. Okay, next slide. So the mechanical treatment is where we actually go in with a clot retriever and pull the clot out. And the way we do that is similar to a cardiac cath, which some of you may have had, but instead of looking at the heart arteries, we're looking at the brain arteries. And so typically an artery is snaked up from your femoral artery in your groin, up through your arteries to your brain, and then into the small blood vessels inside of the brain where the clot can actually be yanked out. It's sort of that device doesn't look very sophisticated to me. It kind of looks like you know, what you put around your plant to keep the deer. Yeah. But our devices have evolved over time, but this is a very effective way to pull out clots causing stroke. Next slide. This is an example of the blue part is actually is carrying the device and delivering it to the site of the clot. The wire mesh is then pushed forward through that catheter so that it can engage with the clot We actually let it sit for a second to try to make sure that it's all getting caught and clotting around that catheter, and then the whole thing comes out. If there are little areas that are left, you can use a vacuum device to try to suck up some little pieces, but that's not always standard. So we actually did a number of trials looking at these kind of big bad strokes where you have a clot in one of the large arteries of your brain. We did them for like 15 years and they were all negative. It was always disappointing. Another retriever trial didn't show a benefit until 2015. And the reason that we probably started to find benefit in our clinical trials in 2015 is that the devices just got a lot better. And then we also got better at choosing who should undergo the procedure. And so in 2015, there was this absolute avalanche of positive trials that came out over a year, and it fundamentally changed how we treat acute stroke. It actually made the New York Times, so stroke neurologists were feeling pretty good about ourselves. And so that was the case within 6 hours of stroke onset. And then in 2018, 2 more trials were published and suggested that even out to 24 hours, thrombectomy could be beneficial for some patients, which was like our dream, because we've been battling this time window, this 4.5-hour time window. And so to be able to potentially offer treatment out to 24 hours is just, just profound. So, the sort of the good and the bad news, that the good news is that most people don't have this type of big bad stroke. But the, I don't know where I was going at that. The good news is that it's rare. And so 10% of patients will be eligible for this treatment if you do have this type of stroke. In the old days, it was kind of like this is bad. Let's call the family. Now we have some treatment we can give. And so it's really, really wonderful. Next slide. Okay, so now just some case studies here. So a 65-year-old woman went to bed normal at midnight. Her daughter heard a fall and found her mother down in the shower in the morning at 6:50. The patient reported that her left leg was normal upon awakening, but then became acutely weak at 6:45. EMS was called via 911, and she had left-sided weakness, new atrial fibrillation, and a stroke alert was activated. When she presented to the emergency room at 8:21, she had left facial droop, slurring of her speech, and was unable to move her left arm or leg. Next slide. She received the clot-busting medicine shortly after arrival at 8:52, and then was taken to the angio suite to remove the blood clot, and thrombectomy was started at 9:11. By 30 minutes later, the blood clot was out and her blood vessels looked normal. Next
So
slide.
actually both.
Yeah.
You can get both.
Okay,
Yes, thank you for
that's-
saying that. Yep. Okay, she was admitted to the ICU, as all patients are after the clot retrieval therapy, and was discharged 2 days later with full strength in her left arm and leg and only mild left facial droop. So this is an example of a patient we took care of. This is, again, this is the kind of thing that we really would have been unheard of before 2015. So it just kind of feels a bit like a miraculous treatment. Next slide. And here's example 2, a 65-year-old, I don't know why all of our patients are 65 in these examples. A 65-year-old man with a history of heart disease, diabetes, and COPD related to smoking is admitted to the hospital for shortness of breath related to a heart problem. After admission, he's witnessed to slump to the left and a stroke alert is activated. So our stroke team doesn't just see patients in the emergency room who are coming out from the community. We also see patients who were already admitted and then develop stroke symptoms, as in this case. He is taken for a head CT. What you're actually seeing there in that head CT is thrombus within the right middle cerebral artery. I'm going to point at it. You probably can see the asymmetry, but this is actually clot sitting in that artery in the right middle cerebral artery. And so he has left facial droop, very slurred speech, and unable to move the left arm or leg. Okay, next slide. So he is administered the clot busting medicine, taken for thrombectomy, and then admitted to the ICU after the procedure. And then we called Karen's team who evaluate him, and actually being able to get a full diet after a stroke is like really good. So he passes for a full diet, returns to nearly full strength aside from some mild left arm weakness, and is able to be discharged home a few days later with outpatient physical therapy. So a really, really positive outcome. So what are some common complications after stroke? You can have residual symptoms that were your symptoms of stroke, like weakness or numbness, trouble talking, trouble swallowing, vision changes. Depression and anxiety are common after stroke and seem to be related to the brain injury itself, not necessarily that you've gone through a traumatic event. So even trying to control, so if you look at people who have had other traumatic events like heart attacks or ICU stays, there's something about the brain injury itself that leads to depression and anxiety. Fatigue is the norm. After a stroke, people are exhausted, and it usually lasts out to 3 to 6 months. So when patients come to my clinic, or a year, when patients come to my clinic after a stroke and they're not tired, I'm like, kind of like, really? It's just absolutely so common. Cognitive changes can occur, especially with multiple strokes that build up. You kind of lose your cognitive reserve. And then seizures. So anytime you have damage to your brain, it can raise your risk of having a seizure. So we can see seizures after stroke.
Could I please ask a question? So the depression that's related to injury at the brain, what about the effectiveness of antidepressants or some medical, like
They're effective.
they are.
And we often recommend, a lot of time patients don't want to go on one. And we say, you know, we're not saying you're going to be on this for the rest of your life. We need to get you over the hump of this post-stroke period. We're talking, you know, maybe a year. Could you try it for a year and then we'll reevaluate? So it's not necessarily lifelong.
Okay, thanks.
So are you saying that depression is different than like a regular?
It appears to be, yes, it appears to be related to brain injury itself, not related to just overwhelming life events, which a stroke is. But even looking at other diseases that are overwhelming, patients with stroke are more likely to get depression.
And does the fatigue occur with a mini stroke?
It shouldn't.
Okay.
Good question. Yeah, because the idea behind a mini stroke is that brain injury didn't
But
occur.
it already went away, kind of. Yeah.
The hard thing is I feel like everybody's fatigued.
Yeah.
I feel like I talk to many people who are like, yes, I feel very robust. Everybody's like, oh my God, this world and life is overwhelming.
Yeah,
So how do you just?
It's a different fatigue.
It's a different kind of fatigue,
sure
okay.
it is.
Yeah,
Bizarre.
yeah.
Yeah.
Depressing.
It's like, no, I often hear it described best as, you know, no matter how much I sleep, no matter how much I take a nap, no matter how much I do or I don't do, I'm just wiped out. I'm just exhausted.
But it just comes on like all of this, for me. It's like I sleep 9 to 10 hours a night. I sleep an hour or I was sleeping an hour to 2 hours during the day. That didn't matter.
Yeah.
And it just would come on and I just like. And it's just totally different. It's not like being tired.
Okay, and then post-stroke recovery. So it is the case that when part of your brain has died in a stroke, it's gone. It's never gonna work again. But other parts of your brain can try to volunteer and take over some of the functions that area of brain was previously doing.
Yay, brain.
What's that?
Yay, brain.
Yeah, right. Because otherwise we wouldn't do rehab. We would just say, you know, too bad for you. So,
Too bad for you.
so neuroplasticity is the ability of the brain to form and reorganize synaptic connections, especially in response to learning or experience following injury. And so the goal after our patients have had strokes is to try to really focus on rehab in the form of physical therapy, occupational therapy, speech language therapy, social engagements, just really trying to use to challenge yourself to use your language if you're having trouble with your talking, use your limbs if you're having trouble with your walking, and really focus on that. There are like aphasia groups, so having trouble talking is a common symptom of stroke. There are groups of people that just like meet up and kind of practice talking with each other. Some patients will, when the commercials come on, when they're watching TV, they'll practice talking back at the commercial. So just trying to come up with a way that you're regularly using, the deficit.
I often tell my patients with aphasia, at least when I was pregnant and had just delivered my child in December in the middle of winter, was all alone, and just talking out loud to my kitchen, like, I'm gonna make coffee. It helped me feel less like a crazy person all alone, right? But it's a good way to practice to animate what you're doing, right? Yeah.
And then next slide. And then we talked about the depression and anxiety. Psychosocial therapy can be really helpful. SSRIs are first line for depression. And then meeting with other people that can relate is really important. So Jessie runs our stroke support group. And I think that is just really valuable to be around some folks that know what you're going through, and you can kind of swap. This happened to me, what happened to you, kind of compare stories, and that can be helpful. Next slide. Oh, and I guess we kind of already covered this. So post-stroke fatigue, super common. You're not doing anything wrong. It's just that it happens. So I think that's it for us. And we're now going to open up the floor for more questions.
Listening to this discussion, I'm flashing back to a time when my mother had Bell's palsy. And this droop on one side of her face was very pronounced. And she didn't feel great, but it wasn't the same thing. But how would we distinguish those two?
That's a good question. There are a few ways you could distinguish. Because of the way our brains are mapped, Bell's palsy affects the entire side of your face, including your forehead. So if you do this, it's going to be flat. Whereas stroke actually affects your lower face. So your forehead is relatively preserved. And so often when we see a patient in the emergency room who has isolated facial droop, because if you have facial droop on the right and your arm is weak on the right, it's not Bell's palsy. It has to be isolated to your face. We're often kind of like, looking at their forehead. So that's one way. Number two, the story is often different. People with Bell's palsy often, they don't have this report of like, ooh, I was normal 1 second, and then the next second I had these symptoms. It's more like, I went to go brush my teeth and the water was kind of coming out of my mouth, or I looked in the mirror and I thought I looked a little funny. And so that's another way. And then the third way is that with stroke, your symptoms are typically maximal at onset and then either stay the same or improve. Bell's palsy actually tends to progress a little bit over hours. And so sometimes I will see a patient in the emergency room and I'll say, I genuinely don't know if this is a stroke or Bell's palsy. I'm going to come back in an hour and reevaluate and see if it's progressed to involve the forehead, or that time can help you with that diagnosis.
But either way, probably 911.
Yeah, because you don't know. I mean, sometimes we don't know, how would you know?
Bell's palsy, you want fairly rapid treatment too, I believe.
Within a day.
If you wait too long, that can become permanent, right?
It's tough. So the treatment for Bell's palsy is prednisone and antiviral, and we think it helps if you can start the treatment within a day or so.
Yeah.
The evidence isn't. It's not like overwhelming, but
yeah,
I would take it if I had it.
I knew somebody in college, a college student who didn't get treatment for a long time, and he had on one side of his, when he smiled, only one side went up, so he had permanent facial change.
Yeah.
Great question. You're listening.
How often might someone wake up with symptoms? Like you said, timing. If you're asleep, you wouldn't know how long
you're right. So,
Is that
it's not
rare
uncommon.
or?
No, it happens.
It's happened.
Yeah, and so what we generally do is we'll take the last known normal as the time that you went to bed, which often excludes you because most of us don't sleep less than 4.5 hours. But there are 2 special tests we could do to try to figure out what time
Okay.
the symptoms started. One is an urgent MRI scan, and then the other is a type of CT called a CT perfusion, which can sometimes help us try to figure out when it started. So
Okay.
that's what I was saying. There are kind of times where we break the 4.5 hour rule, but we're kind of trying to estimate that it happened within the prior 4.5 hours.
I had a friend who had a hemorrhagic stroke, and after, in the process of her recovery, she, our book group read A Stroke of Genius by written by a neuroscientist who had a stroke.
Yeah.
And she found that really encouraging because the author actually pointed out positive effects of her attitude that the stroke brought, like
It was my stroke of
her
genius or my stroke
self-critic
of
kind
insight.
of calmed down a little, I guess, anyway, but it was interesting that the stroke in some ways was seen as a positive on her mental health or the way she was. I don't know, I just thought that was interesting. A stroke of insight.
Oh, yeah. Yeah. Great book.
I think very good.
And we've got a question from Larry.
Yeah, I'd like to make a positive personal testimonial on this. It's well over 40 years ago that I was diagnosed with some severe problems developing. For example, my femoral arteries were becoming blocked. They had bruits, and also my blood cholesterol was 330. And at that time, it was, well, that's all right, you know. But the American Heart Association was saying, well, you should get it down. And I just did some simple things like the minimal diet and exercise type things. And the bruits went away in a couple of years. And then I realized that, and as science advanced, I realized I needed to do more. And in contrast to many, many members of my family, I've been spared. So far, so good, these things. But I have a risk factor, which is most people don't know about, but it's genetic. It's very, very high lipoprotein A. You don't hear much about it because there's the common knowledge is that, well, there's nothing you can do about it. But in fact, actually, once again, diet and exercise, even modest, appears to help a lot. And I'd have to say that it looks to me like a pretty important factor that indicates your progress or how you're doing is the so-called C-reactive protein. It's a kind of a generalized measure of inflammation. And my LPA is way off the charts. I'm more than 0.1 percentile. But I've kept my C-reactive protein down, way down. And that's diet and exercise, and nothing fancy, just moving the blood, preventing pooled blood. You get moving in the morning a little bit and just get the blood circulation started. And and then some dietary factors. It's a long story, but there's a lot that can be done. And I see some pretty important things happening in science, but I just don't know where they stand. I'll pose this question to you. And that is that it's a decade or so ago now that I saw a number of studies indicating that early stage ischemic, that is low oxygen, caused death, cell death, could be reversed by some fairly low molecular weight compounds that could be applied and would circulate pretty quickly or penetrate pretty quickly. But I haven't heard anything more at all about that. But that really adds a whole new dimension to what we're talking about for people who have had a bad attack and they have this ischemia or oxygen deficiency that's lethal in the tissue level. But it looks like there's something on the horizon that could correct even that in early stages.
Yeah, it's interesting. So the idea is to provide like we call it hyperbaric oxygen, but like, just like flood the brain with oxygen to try to help.
It may involve oxygen, but it may also involve the cell membrane permeability.
Yeah, so our studies looking at kind of hyperbaric oxygen have not been promising. There's also an idea that you could potentially cool the tissue, so that there's like a helmet, an ice helmet that'll try to cool your brain and those are in very preliminary stages, so right now we don't have anything, you know, imminent in the next few years that's novel, but I think in the next 10 to 15 years it's certainly possible.
Any other questions?
So this comes from a clot in your brain. And does the clot start in your brain or does it, I mean, like the carotid artery kind of thing, or is that?
That's a great question.
Yeah,
And
well,
I-
it can be a few different reasons, right? One was the AFib, a clot forming in your heart that then travels into your brain and blocks blood flow. Another is carotid artery disease, clot breaking out from that carotid artery traveling upwards, right? So it's something traveling from somewhere, but there are also narrowing of those arteries deep inside of your brain, usually related to years of high blood pressure. So less an actual clot in there, but really just those arteries kind of collapsing in on themselves after just giving up from years of high blood pressure. So kind of few different reasons why it happens, and it's part of the fun of our jobs is figuring out why.
All right. Thank you. Thank you very
Well,
much.
thank you.
Thank you so much.
I have some fast handouts, and then some stickers too, to put on your, or magnets, excuse me, magnets to put on your fridge, okay?
Okay,
Could I have a closing prayer before we depart?
sure.
All right. Let's join our hearts together in attitude of prayer. Loving and present God, give us strength and health for anyone who has experienced a stroke. Please bless the medical professionals and caregivers who surround stroke patients. Give us all courage to face our health challenges with the peace that you are present and loving in all aspects of life. In your name we pray. Amen.
Amen.